tachycardic, because it actually seemed like this tachycardia was keeping her alive with this low blood pressure. And then all of a sudden she had this junctional rhythm at 65, and her blood pressure got even lower. At this point, you could see her diastolic is really low, right? So she's not vasoconstricting. Her heart's really not working too well. And so at this point, we actually bolused her with 1 unit per kilo of insulin and AMPA D50, and actually even gave her some vasopressin. Just went to the crash cart, got 40 unit vasopressin we use in a code, bolused her with that. Her blood pressure improved, started her on a 1 unit per kilo per hour insulin infusion, which was about, in her, it was about 60 units. And she eventually, she was also on norepinephrine, and she did survive, so I feel somewhat, relieved that I could stand here and actually talk to you. So it was an interesting case. We also did, with this QRS, we did give her some sodium bicarb, and again, until we saw that resolve. All right, so it's kind of hard to remember all these things, right? So I'm going to switch to some take-home points. So this is easy, right? IV fluids, you just fill the tank. Epinephrine is maybe okay, but remember that potential problem with beta 2. Glucagon probably is a good agent to use. You may need bigger doses, 5, 10 milligrams. You may need infusions, but remember the adverse effects really is the emesis, so vomiting. Giving it slow is probably better. Calcium with your DIG patient, maybe not so scary. There certainly is, the mechanism makes sense. There certainly are cases where that may have happened, but I think with the more recent studies, it's showing that that's probably less of a concern of getting that stone heart when you're treating hyperkalemia in the DIG poison patient. Norepinephrine, probably a good choice because it increases the heart rate, vasoconstricts, so you got both effects. Isoproterenol, I just probably wouldn't use that. In fact, I don't think I've ever seen a patient on it that was doing well, actually. So, would not use that. High-dose insulin, don't be afraid. I think this is a great therapy. I think we don't use it enough, early enough, or a high enough amounts, actually. Sodium bicarb, remember, bolus them until they're better. And this is not the situation where they have a normal blood pressure, right? The normal blood pressure, the QRS may be a little bit prolonged. I don't think that's when you go crazy and bolus them. I think it's when they're hypotensive and they have a prolonged QRS. Levosimendan, stay tuned, who knows, maybe we'll be using this. Some of the machines, if I certainly can work, maybe not such a big problem with a DIG poison patient. Remember the lipids? I'm sure you won't forget after this conference. If you got a fat drug and you want to get rid of it, it looks like the lipids could work. And maybe it's a combination. Maybe it's with glucagon. Maybe it's with insulin, like that nebivolol case. Vasopressin is a good vasoconstrictor. So if you see that vasodilation in the patient, a low diastolic blood pressure, then this may be helpful. And we even, in that case that I talked about, we did use that as well. So phosphodiesterase inhibitors, probably not a great choice. Dopamine, pretty popular amongst, in the medical community, but I think with toxicology there are a lot of limitations to it, but maybe an initial starting pressor may be fine. So there they are. We've gone through our perfusion salad bar menu. Hopefully this has kind of set you up for dinner, a little pre-dinner salad. I do want to just have a moment of silence for the animals that died and survived for all these studies, so we could, be very erudite and talk about all these things. And even the humans that we've, tried all these things on. So, okay, we have that moment. And don't forget, just dig in to that salad. Hopefully you know the mechanism. Hopefully you know what's good and bad about each of these, and you can apply it to the particular occasion. Thank you. And now, if there are any questions, any additional, I guess?
Well, thank you very, I'm sorry, you have a question.
I just have one question.
Yeah.
And also my compliments on two very excellent presentations.
Thank you.
Could you give me some idea when you might favor vasopressin over choosing norepinephrine? And under what circumstances would you consider using both?
Well, I think in the vasopressin would be in, say, a case, say, for example, it's an alpha-1 antagonist, so they're vasodilated, and that's the only reason that they're hypotensive. You could use vasopressin as potential, vasoconstrictor, because that's all it's going to do. The heart's working fine, but they're vasodilated. You give them vasopressin, and they could vasoconstrict. Norepinephrine will do the same thing. It'll just increase the heart rate. It'll increase the contractility of the heart. It's probably easier to get the norepinephrine and get that going. And if that doesn't seem to be doing the job, I think you could add the vasopressin. Okay.
Thank you very much, Dr. Bryant and Dr. Cumpston, and for everybody for attending. And please remember to fill out their evaluation forms. Thank you.